Globally, 300 million people are living with asthma. It is expected that by 2025, asthma will affect an additional 100 million more adults and children.
Good morning. My name is Michaela Muscat. Together today, we will analyse a case study where a provisional diagnosis of acute severe asthma is made.
I intend to illuminate a common clinical manifestation of asthma whilst explaining the pathogenesis behind the clinical manifestation. I also endeavour to address a high priority nursing intervention aimed at improving the clinical manifestation discussed. Before we delve into the case study, let's explore asthma a little more closely. Asthma is a prevalent chronic airway disease related to type 2 cytokines, stimulating mucus overproduction, airway eosinophenia, bronchial hyporesponsiveness, and immunoglobulin E synthesis. Symptoms of asthma fluctuate, although they are commonly identified by shortness of breath, a cough, and chest tightness. Viral upper respiratory tract infections or exposure to aeroallergens and air pollution can worsen asthma symptoms, triggering periods of exacerbation. During these periods of exacerbation, respiratory failure is expected. Now that we know what asthma is, let's get to know our patient. Jackson Smith is an 18-year-old male admitted to the emergency department at 9 p.m. with severe breathlessness. His family informed us that he has a history of asthma that has been diagnosed when he was 2 years old. On admission to the emergency department, the clinical manifestations were a respiratory rate of 32 breaths per minute, SATs of 92% on room air, a pulse rate of 130 beats per minute, auscultation of lungs, diminished breath sounds and widespread wheeze. Chest x-rays also show clear and hyperinflated lung fields. It is also noted Jackson has severe dyspnea.
So, what is dyspnea, and what is the pathogenesis causing this clinical manifestation? Also described as the shortness of breath or breathlessness, dyspnea is responsible for almost half of all tertiary hospital admissions. Dyspnea, observed as a symptom rather than a sign, is identified as a subjective experience of breathing discomfort. Airflow limitation has a central role in the pathophysiology of dyspnea in asthmatics and is caused by an array of changes in the airway. Examples of airflow limitation leading to the clinical manifestation of dyspnea in asthmatics involves bronchoconstriction, airway hyperresponsiveness, airway edema, and airway remodeling. Let us have a closer look as to what bronchoconstriction and airway remodeling are and how they cause airflow limitations. In acute asthma exacerbations, bronchoconstriction occurs. Bronchoconstriction is the act by which bronchial smooth muscles contract. In periods of exacerbation, the airways quickly narrow as a response to exposure to various stimuli. Stimuli may include allergen or irritants. Allergen-induced bronchoconstriction occurs due to an IgE-dependent release of mediators derived from the mast cells. The release of mediators such as tryptase, histamine, prostaglandins, and leukotrienes instigate the smooth muscle contraction in the airway. Inflammation in asthmatic client airways involves an interaction of many cell types such as neutrophils, eosinophils, lymphocytes, mast cell activation, and epithelial cell injury. Chronic inflammation will initiate airway remodeling and cause intermittent airway narrowing. As a result of a progressive decline in lung function, permanent structural changes may occur in the airway. Airway remodeling refers to the activation of structural cells that change the airway's anatomy, increasing the risk for airway responsiveness and airflow obstruction, resulting in increased chances of the patient becoming less responsive to therapy. Though the pathophysiology of repair and regulation in remodeling is not yet well understood, these processes remain crucial to understanding the tenacious characteristics of the disease and diminished response to therapeutic response. It is imperative dyspnea is not overlooked, as the consequences of leaving this clinical manifestation untreated is life-threatening. Dyspnea can be life-threatening due to increased resistance to airflow, bronchial closure, and uneven ventilation distribution. It is critical to recognise warning signs requiring immediate attention since the patient could be suffering from a life-threatening cause of dyspnea. High respiratory rate, hypertension, altered mental status, cyanosis, stridor, hypoxia, breathing effort without air movement, chest wall retractions, unilateral breath sounds, tracheal deviation, and an unstable arrhythmia are all examples of these warning signals. The appearance of any of these signs or symptoms requires immediate assessment of the patient as they collectively indicate lack of oxygen in the body. When asthmatic symptoms such as dyspnea are present, it is highly likely lack of oxygen is reaching the patient's lungs. This can cause cessation of breathing, medically referred to as apnea. Dyspnea poses as a clinically confronting clinical manifestation to manage, as it is common for symptoms to persist even when unearthing the rudimentary cause. A high priority intervention aimed at improving dyspnea is the administration of medications. Bronchodilators are medications used to aid respiration by dilating the bronchi. These specific medications are helpful in symptomatic relief or prevention of dyspnea associated with asthma. Short-acting beta-2 agonists are an example of bronchodilators. These medications aim to relax the muscles lining the airways that carry the air to the lungs. This should be the initial treatment of choice for acute asthma exacerbation. Examples of short-acting beta-2 agonists include salbutamol, levalbuterol, and terbutaline.
That was the last aspect of focus in this presentation. To summarise our findings in this presentation, let us review what we learnt. My presentation aimed to illuminate a common clinical manifestation of asthma whilst explaining the pathogenesis behind the clinical manifestation. Throughout this section of the presentation, I discussed the dyspnea Jackson-Smith presented with and the array of pathological causes ranging from bronchoconstriction to airway remodeling, which may have caused the clinical manifestation. I also endeavoured to address a high priority nursing intervention that aimed to improve the clinical manifestation of dyspnea. In this section, I highlighted the importance of administering the appropriate medications. Nurses need to appreciate that asthma is a severe and widely occurring health problem among adults and children. When symptoms are left untreated, asthma can cause life-threatening health problems. Thank you for your time today.